a big chunk of my money. I'm going to record now. So I'm going to start over again. We do discuss clients that we have, and because we want to learn with them and have the real world examples and that sort of thing. And so the confidentiality is extended to all of the class people. You don't, nobody talks about, oh,
Okay.
you know, let's see, or somebody is seeing a professional basketball player and blah, blah, blah. We know better than
Right.
that kind of stuff. But the reason why this is so helpful that people are working to some extent while they're going through this class is that we can problem solve. We can help say, okay, I mean, this is the platform for, I got a client with a thing, and then I did this thing. So yesterday, Alyssa, you were the client with a thing. You had that fall related to a shoulder injury. And then I mentioned that you said it was much better today, much better.
Yes.
And then I indicated that it was probably primarily soft tissue then.
Yes.
Because what happens is that if it's stiff and sore and you do something to it and there's an underlying joint injury, what you've done is altered the guarding response, you know, how everything clamps down on it and things. And then the methods we were using, that inhibitory pressure, that they are um, um, preventing that from moving around. So then you take that away or reduce that, then the injury, the underlying joint injury, can kind of raise its ugly little head. And that's one of the ways you know that it's a joint injury. There are other ways. And it's not that we can't do what we're doing, but we have to think about it more broadly. Now, if you had been in class and we worked on your shoulder and it was just after you had taken the fall, within 2 or 3 days, that would have been in the acute phase. And I would have been much more cautious about using those methods because I would have made an assumption that this was guarding and it was purposeful and it was there for a reason.
Okay.
And then you also went to chiropractor.
Yes.
Which means that you had other interventions. And one of the things that we look at in AP is the idea that there probably is some other professional intervention, whether it's a chiropractor, a physician, a mental health professional, an athletic trainer, you know, whatever. And so we have to always gauge what we're doing in comparison to what's going on, and that we sometimes even have to learn, be in a communication, a back and forth communication. So we have to learn how to do that.
Yeah.
So, and then Linda, we worked on you, and that was more related to just general practice, right? I mean, we weren't targeting, there wasn't a condition right in our face, like with Alyssa when she had that fall. But we did work on areas that had you had history with.
Yes.
A shoulder injury, stuff around your hip, the knee, that sort of thing. So what is your experience this morning?
Every time I got up, because like I said, I had a lot on my mind last night, so I was up at 2 o'clock. And I would get up, and usually I'm pretty stiff, but this morning I got right up and started walking and with no pain.
So
Great.
I know.
Yeah, you more with the hip stuff.
Yes.
With the hip stuff. Whatever happened, your gait immediately improved.
Yes, it did.
Stride length, how big of a step you could take. You didn't have that sense of using your upper body to propel you forward, and then your legs follow you behind.
I
Some
was
of,
standing straighter,
Right.
with no pain, to force myself to stand straighter.
So as a review again, because I didn't have the recording on, the methods that we were working with yesterday is what I call inhibition techniques. They're working primarily with the nervous system, although you're always going to get an overlap into connective tissue and fluid and all of that. We're trying to reduce motor tone or normalize motor tone. So the basic approach is general broad-based compression into the belly of the suspected tissue, and movement coordinated with that. And we think, just for learning purposes, we think, okay, we're on the latissimus or we're on gluteus medius, but we're not. I mean, we are, but it's just impossible to totally isolate that. So, but for learning again, and in the textbook, we looked at latissimus and pectoralis major, which are the adductors of the shoulder. And then we also looked at pectoralis minor, which is part of the scapular stabilization. And then we paired that up a little bit with looking at similar tissues on the hip, which were the adductors themselves. We also palpated for the hamstring attachment at the hip, those two, because they're in such close proximity that if you don't differentiate between the two, it's common to be on hamstrings when you're trying to get onto the adductors. So we wanted to make sure that you could feel the difference on that. And then we looked at gluteus medius and tensor fascia lata, and gluteus minimus. And those are muscles that are, to a little bit of an extent, they pair with the deltoids in terms of abduction with a little bit of flexion, extension, and rotation. So there's a method to that madness. And I forget who I practiced on, but maybe it was Luke. We inhibited the adductors in the lower body, the actual hip adductors, and then had him move the shoulder adductors in and out of range. And you could see an increase in that range of motion. And then I think it was you, Alyssa, that we would work on something and you would feel it in your low back or something like that. So, so that's a pretty good summary of what we did yesterday and where we were going with that. And I'll continue to come back to Erica. Now you've seen us do that at the Pistons. You've seen us.
I have.
Yeah, and it always surprises them, and they always, if they haven't had their first exposure to it, surprises them. So we don't want to come across at all like have any magic or we're doing anything, that's, where we've got gifted hands or anything like that. So we always need to be able to explain logically why we're doing stuff. Not so much those characters, although they're vulnerable, but people who are in chronic pain, they are really vulnerable. And they'll start to think that, you have some sort of magic touch or something. And that's really not the case. None of this stuff is going to be, really part of what's going on. I did something, I think I did it with you, Alyssa. We were working on that shoulder or something, and I was playing with positional release, and I had the symptomatic area pressed down, so it was giving you a sensation. And then I said, so positional release would be, let's see if we can find a position where you can put yourself where that sensation diminishes.
Right.
Remember that? So so we've got direct techniques. So the one where we just pressed on it and then we had you move back and forth, that's more of a direct technique. But positional release is more indirect. So direct is you're going right into the symptom, right into the tightness, right into the lesion is another name that they will use. And indirect is you're trying to find an ease. So another term you'll hear me use is ease and bind, ease and bind.
And also you used loose packing.
Yes, yes. And so I'll come back to that. Don't let me forget.
Okay.
And so so at first I had you move your arm and stuff like that. And then I said something like, okay, just for giggles, let's have you move your neck and that sort of thing. And it was surprising, wasn't it?
Yes.
Move an area that was totally unrelated and get a significant sensation diminishing, you know, under where my pressure was at. And then I said to you, okay, so let's do this because the eyes, the proprioceptors, now that's kitty cat. Hi, kitty cat.
Yes.
The proprioception in the eyes and in the neck
You're gonna step on my keyboard.
has a lot to do with which muscles are activating and which ones are inhibiting as we're trying to move or turn or whatever. And so I said to you, look at where I'm pressing. Just turn your head and eyes and look at where I'm pressing. And that made it increase, which would make sense because your body thinks it's going that direction. And it's preparing, it's tightening up, you know, it's activating those movements. And then I said, look the total opposite. And it diminished. It was like finding a positional release. In addition to that, we've got our idea of muscle energy stuff, which is contract, relax, antagonist, contract. So when I had you look at it, that was contract that I had, but indirectly, not the muscle itself. And then when you started to look away, that was relax. And then when you got to the end of that range of looking totally away with it, you're telling your brain you're going in the opposite direction.
Right. Okay.
So that's antagonist contract.
Okay.
And because there's so many receptors, postural receptors and stuff in the neck and the eyes, this is a really effective way to use those methods. Because Erica can tell you, and I'm sure you experienced, you tell somebody to contract or push against you, they push way too hard. And that actually overrides any kind of signaling you're going to get. But then you got to logically explain to them why you're telling them to move their eyes in a circle or move their head in a circle.
Are you there?
Look at you like you got a horn growing out of the middle of your forehead. So have you ever had anybody question you about that, Erica?
You know what? I missed your whole question. I keep losing you. I don't know if I'm having weather issues out here or what.
Have you moved around the house?
What's that?
Have you moved around the house?
Yeah, I came into the best room I got for this, so.
Turn your video off and just leave the voice on. That sometimes helps.
All right, let me.
Okay, can you hear me better? Oh, there's. Okay,
No,
see
hold on.
now. There.
All right, I got it.
That's just your air. That's just your phone. Do you hear me better?
Yep, I hear you.
All right, so you're up in North Branch, aren't you, or West Branch?
Yes, ma'am. North Branch.
Yeah, the signaling. You know, I used to live up there. The signaling there sucks.
Oh, it's terrible. It is unbelievably bad with 4 boys.
So the question I asked Erica, I was talking about some of this positional release and using, you know, turn your head in a circle or turn your eyes in a circle or look at it, look away. They get a result and it kind of freaks them out a little bit. Have you had that happen with any of your clients?
No, maybe surprised, but not.
Not freaked out?
No, not at all.
Yeah, and how did you explain to them how that works?
Well, I just explain that everything is all tied in. I don't get into real super big explanations with any of my clients on stuff because I don't even feel like half of them listen to that. They just want to be fixed by me. The athlete type do, but my home clients never seem any interested, sadly, in that at all.
So sadly, so let's move this into an ethical discussion. What is our responsibility for educating our clients? Do we force it on them?
No,
Well, I do.
I mean, obviously I don't, but I don't know.
I think that I do think now, not like they're in a class or anything like that. There's Lauren, she ate her pancakes. She's still eating her pancakes. I don't even want to see it.
I know, right?
I'm sick, so my parents make me breakfast and keep me in my room.
Aw.
So, if we look at Ann Blair Kennedy's definitions, this is something we did back in the entry-level program where I talked to you about, okay, here's the definition of massage, and here's massage therapy practice, and here's the differentiation between the two. So lots of people can do massage. Massage is a manual therapy. Chiropractors, it's certified nursing assistants, estheticians, massage as a thing to do is pretty generic. But massage therapy has a different level of expectation on it. You're using it to achieve some sort of an outcome. There's our 4 outcomes: relaxation, well-being, stress management, pain management, functional mobility. And it's your primary approach as opposed to it being secondary to what else you would do. So chiropractic has primary approaches, but they also have massage in their scope of practice. Estheticians, their primary focus is focusing on the skin, but massage is part of that. But they're more focused on the skin as opposed to functional mobility. So as we take on the responsibility of massage therapy and we put that into a primary practice, that's much bigger now. There's a business responsibility, there's an ethical responsibility, there's responsibility for safe practice, there's education involved with it, there's documentation involved with it, it's the whole thing. So one of the things that Ann Blair Kennedy pointed out, and actually did a study with it, is what is our responsibility in a massage therapy practice for health messaging? Now, a lot of times people see that as self-help. Okay, here's a little stretch you can do, or, a general exercise is helpful, or here's some things you can do to support sleep, that kind of stuff. I interpret that as much bigger. I think that in a massage therapy practice, especially as we are starting to work with more complex clients, which is the intent of the advanced practice program, the only way they are going to be able to take on their own client-centered understanding of this is if they have information. Otherwise, they're not ever going to be able to frame all of this stuff. And so we do need to teach them a little bit. And Erica, are you still there?
Yep.
Okay. You've seen me do this at the Pistons very deliberately. I kind of put a little sense of humor on it, But I explain what I'm doing, and I'll even say, okay, what'd you learn today? I'll even quiz them when they walk out. You see me do that, Erica?
You do that a lot. I am not good about doing that at all. I don't know.
So maybe this year, Erica, that will be part of your own focus, is trying to absorb some of these explanations so that you're not going into an hour-long lecture. You know, you gotta be as efficient with this as you are with applying a method, because there's a certain value in zoning out and not having to think. So I'm not suggesting that, but using the Pistons players as an example, they may only be with us for a season. And there's a lot of stupid stuff out there in massage. And I have seen players hurt, or at the very least get ineffective care. And I feel a responsibility to give them enough information so they can make good choices about the next massage therapist they're going to work with. At the very least, to keep them from being hurt. Because people see these athletes and they think that they have to work really heavy and hard and all that kind of stuff and do all this specific thing. And you actually got to be pretty cautious with them, because they're at that prime peak performance, which the next stage of that is injury. So you got to be kind of careful with them. And being able to give some simple explanations like I just did with, okay, look, I'm going to have you help this thing normalize. And I'm going to do it by turning your eyes and your neck. And that really activates certain receptor mechanisms that are focusing on your posture and your stability. And it can seem weird, but it really is not. And so now I'm going to say, I'm going to press here, and I'm going to have you turn your head towards it and turn it away and turn it. And so now they have a place to frame that. Where this falls down for me, because I've worked with so many different athletes and they're all over the country, is that they try to find another massage therapist that kind of has this ability to integrate multiple methods into what's going on with the massage. They have a hard time finding somebody that knows how to blend this in. It gets frustrating for them. Okay, back to you, Erica. Have you ever had one of the guys you're working with say, gosh, nobody's ever done that to me?
Yes, that I have had happen.
And what was that? What did you do?
I was leaning into the shoulder and having him reach down, up, and out in front of him. When
Yeah.
he was side lying, and he got better range of motion after that.
So, and nobody's done that to me.
Never. He said nobody's ever leaned into anything or pinned anything down or no.
So I am on this committee, this think tank thing, and on Canvas, on the AP course, announcements. That's where I stick everything. And that's new to you, Erica. That's not new to these three. And I will put the link to this committee. They were going to actually have a conference this year, but they had to postpone it. They had to cancel it because of COVID. And they're going to have a free kind of webinar thing here this spring sometime. And it's a collaboration of manual therapists across the globe. They're all over the place. And I was recruited for massage therapy. And we're trying to find where common ground is in the terminology and the mechanisms, and then kind of maybe what's different. So there's chiropractors, physical therapists, structural integration. That's the Rolfing kind of group. It's evolved beyond that particular focus, but there's the osteopaths, massage therapy, and we're working collaboratively to try to find a language and to find evidence and find commonality and also find differentiation. And it's frustrating. And the last meeting we had, I put forth that thing that I teach you guys. Here, we got 4 outcomes. We got, pain, those. We got 4 approaches to care: palliative, restorative, condition management, therapeutic change. We address these by application of a mechanical force, which is a push or pull into the tissues. And the way we do that is to compress, glide, knead, elongate. You know what I'm talking about. And then that stimulates the nervous system, and or has a mechanical effect because the tissues are now loaded with either compression or tension or friction, shear, or a combination of. And then the nervous system has to respond, and then you can also get a local effect. They had never seen it. This group that I work with, they had not seen it laid out that way.
Nice.
And they were talking in terms of method. So they were talking pin and stretch and trigger point and deep tissue and muscle energy technique. And I said, that right there is what separates us, because we think these are unique things, and they're really not. What's unique is our intention for focus.
Right.
And so chiropractic may have more, although they're evolving, they might have more of an intention for focus on joint function, whereas the osteopath, they are more form follows function and function follows form, and they also deal with things like lymphatic pumps and that sort of thing. And so, I don't know, this is going to be an interesting exercise. I took it on because I am frustrated with the massage therapy organizations, that they're still stuck in the modalities. I'm going to do Swedish massage here, and then I'm going to do myofascial release there, and then I'm going to do cranial sacral here, and then I'm going to do reflexology there, and then I'm going to, and we're not the only occupation that's stuck like that. So we'll see how it goes. But I will post the link for that, because they are going to do this free webinar, and eventually there will be an on-site one. But almost all of us are pretty much in agreement that should be streamed as well, so that people can see it. And eventually there'll probably be some fee for these. But the first one that's going to come up the intention is for it to be free. So that's pretty cool. But we're grappling with these same kinds of things that we're wandering around with here. So, so I gave you a task for this year, Erica?
Yep.
Yeah. Did I finally get you over using your thumbs? Your hands?
I'm a little slow today. I'm headachy still, so you're not going to get real coherent answers out of me today.
We'll come back to Erica throughout the program. She suffers from, for real, migraine headaches.
Oh,
I'm an idiot when I take my meds too. There's like nothing left.
Yeah, so a lot of people that have migraine headaches probably are having muscle tension headaches. And there is a very big difference between the two. So, all right, I want to share screen here for a minute. And try to, not that. I gotta reduce my view down here for a minute.
How's everybody doing?
Yeah, talk to each other while I wander around in here.
How you doing, Alyssa?
really good. How about yourself?
Been better, but
You've been
I'm
better.
good.
You're not feeling
What's
good?
going on, Lauren?
May have contracted the virus at some point.
And how do you feel? What's the
I
symptom?
surprisingly feel fine.
That's good to know. I hear of so many cases, but is it so many cases of the sniffles, or is it so many cases?
So
you know?
what it mostly is like a really bad fever for a lot of people.
Okay.
You're
Because my current boyfriend actually got it, and he was having like the deep, full body coughs and everything,
Oh, okay.
and his temperature was really, really high, even though he felt really, really cold.
Lauren, you sound congested, but you don't think you're showing symptoms?
The only symptom I want to say I have is the fact that I can't smell anything.
Okay.
Interesting. Huh.
Yeah.
Yeah. So can you characters see this dashboard?
Yes.
Yeah.
Okay. Erica, you might want to
Yeah.
put your phone or your video back on so we can see your miserable little face.
Let me put it.
Don't worry, you're not the only miserable one here.
All right. So
Both good.
my AP course is green. I don't know for sure what color you guys' is.
I have green.
You guys, your
Heal.
entry level course is still up, by the way.
Yeah.
Did you know that, Linda?
Yes.
Okay. So you can still get to those test questions and everything I was talking about.
Yes. Mine's gray.
Okay.
My AP is gray.
All right. So here it, yeah, I don't know why they don't always come up the same color. Okay. All right. I'm going to click on that. I just want to make sure everybody's found that. There it is. And so here are all of the elements related to the textbook, which you guys don't have the link for yet. You don't have the code to get in for yet. I'll follow up on that. But if you go into the course, you can get into this stuff. And so there's a glossary. If you've still got Flash, there's a general massage protocol here. But this book was written in 2007. 95% of it is still relevant. It's not dated. So a few things are, but unfortunately, it did not sell. I'm kind of 5 years ahead of the game sometimes. So that's why it's only available electronically too. So, and so when I say there's test questions, if we look at chapter 1 here, here's a bunch of links that go right to PubMed, and they give you search terms here. So that's the research part of all of this. And then those questions I was telling you about that you work on here, this is where you find those. Now, that's not up because I'm on as an instructor. If I put it up on preview here, you'll see it. There they go. Those are the ones that go to your grade book. And eventually you'll need to wade yourself through those. Those questions are the type that will prepare for board certification, which is a voluntary second level credential over and above licensing. So we can discuss that more later. Here's where those announcements are at. And you can see I've got the Zoom links here. And this is where I posted the stuff for the schedule. And this is where I will put stuff, just stuff. It's in the announcements. So I'm going to go down and open up my book. Vital Source, there it is. All right. And this is what it will look like. And let's get to the table of contents here. Okay, so read the front matter. When you get access to this, read the front matter. It talks about my journey with the healthcare community. I also had two other authors on this book, Glenn Hemel, who is a research professor, and Dr. Leon Shadow, who I've talked to you about before. He passed away a year ago. So unit 1 is focused on how we respond and adapt to massage in an integrated healthcare structure. Unit 2 is going to talk about, is more massage focused. And this is where we've got increased information, indications, anatomy review, sanitation, a general review of massage, assessment. And then this chapter right here, chapter 10, is the one we are working on for the next, well, it started on yesterday, but are working on for the first 6 months of the program. So I'm gonna hit that and kind of go through this with you, because these are words that I have mentioned. So I've got the indirect techniques and then direct techniques. Sometimes this is called functional technique. And then we're going to get into fluid dynamics. That's later on in the program. More information around lymphatics and that sort of thing. Here is more focus on indications and contraindications for that. So this is a quick journey. Here's circulation. This is just an expansion on what you already had in the entry level. You getting that?
Sure.
We need the Evelyn Wood speed reading course.
Same with the connective tissue focus here. There won't be a lot different than what you got in entry level, but there will be more comprehension and level of understanding with it. Now, the trigger point thingy, those spots, those symptoms that we said should feel familiar when we were doing the inhibitory pressure stuff yesterday, they can be classified as trigger points. And I've said to you before, there's a lot of controversy over this, but I still think it's a workable concept. So that's kind of this arena here. So when we press on something and it recreates a symptom, two things are happening. Either it could be this trigger point phenomenon, or you're on a nerve impingement area. Soft tissue is pinching on a nerve somehow.
Wow.
Da 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 dee 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 dee. Now here is your least packed position of the joints that I mentioned yesterday. This is where a joint will go when it's hurt, because it's got
Wow.
space in it. So that's coming up. Here are a few Asian-based approaches that kind of fit in pretty good. And here's where we are starting. So God forbid we start at the beginning, right? Okay.
It can't be a class if it doesn't start at the beginning.
Yeah, well, you can start reading at the beginning.
Jump in.
Here's what I want you to notice in how this section is laid out as we go through these methods. Now, we didn't work on scalenes, but Alyssa, you were there yesterday when I was working on this a little bit with Luke. So you have a frame of reference. So what it will do now, it gives you the symptoms, tells you how to assess it, gives you the procedure with pictures, and then gives you a little bit more overview on that. This section is all laid out this way. So let's get to one of the ones we worked on yesterday. Okay, here's the hamstrings, although that wasn't our primary focus. We did address that. And so the symptoms are pain felt at the proximal and or distal attachments. So we didn't do distal attachments. So when we target hamstring specific, it will be up towards the hip and down by the knee, accompanied by a sense of stiffness and aching. Because this is meant to be healthcare, I use the word patient here to substitute client. The person hesitates to run and then stop quickly. So that falls into something called acceleration and deceleration. Lots of times the pain happens or the discomfort occurs when they try to reverse a movement or stop a movement, or when they're just starting to initiate. So Linda, when you were getting off the table, or when you were getting up and you were feeling stiff prior to when we worked on you, usually if you moved a little bit, it got a little easier to do.
Yes.
You were having symptoms as you were initiating movement.
Yes.
Okay. And I did not assess for, do you have symptoms when you were decelerating or trying to stop that movement and turn? So that's an added assessment. We did do that a little bit, but I didn't point it out when I was having you move things through a full range of motion.
Yeah.
So then we have to test to see whether the muscles are short. Can the patient bend at the waist and touch the toes while keeping the legs straight? Well, nobody really needs to do that. They just need to get to 90 degrees. Can the person flex the knees to touch the nose and then the nose? That would be a stretch. And then it goes through and it talks about finding the area. So here's some more. So this should look familiar. Does that look familiar to how we were working on some of this?
Yes.
Okay.
Yes.
And then this lower part here is how we would get to the distal. So you've got a picture to reinforce what you're doing with stuff. Subscapularis we didn't do. Okay, we did pectoralis major and pectoralis minor. So this should feel supportive. What we didn't do are the rhomboids and anterior serratus, because that required a different positioning that I wanted to focus on. So we'll have to come back and work that in. So if this is the case, this group, the person generally complains of pain between the scapula and reports the back feels tight and fatigue. And sometimes there's a specific tender point or aching in the upper rhomboid area, which is kind of between the top of the scapula, between that and the vertebrae and through there. Now, when we get to the latissimus area, it'll bring in the shoulder issues. Okay, so that's subscapularis. We don't want to do that. Okay, does that look familiar? That's how we were getting to the pectoralis. Remember that? Where we were lifting that right up in there. And for the way I taught you, I had you pulling it as opposed to lifting it and pushing it. And then this is a preview on how we're going to get to the rhomboids. And then pec minor, got right into it at the clavicle. That's the diaphragm. So as quadratus lumborum we'll get to next week or next time. We started a little bit with the deep lateral hip rotators. So again, symptoms. The person complains of deep pain in the gluteals. How we perform our assessment. You look to see if there's external rotation. You palpate to see if there are tender points that recreate the symptom. And then here's your procedure. Apply inhibiting compression with internal and external rotation of the deep lateral hip rotators. Use forearm to apply compression while moving the hip into internal and external rotation. Incorporate muscle energy methods to facilitate the release. Perform stretching while the patient is in the supine position. Now, we didn't do this whole thing. We were just trying to find the muscles on the spot and the main movement that you would use. So that starts to look familiar where we were doing them. And we had them on their side for this. And I chose to do it that way because you guys already know how to do it like this. I also teach you some things that aren't in the book. And so don't be surprised if not everything is in the book. So obviously latissimus is not in there, the latissimus one. Now I have a reason for that. And the reason for that is I'm not always sure the person can perform something safely without actual instruction with it, so I won't put it in a textbook. So not everything will be in the book.
What could go wrong if you're trying to do the latissimus without visual instruction?
Either get too low and they actually bring out too much bruising.
Okay.
Or they don't go down, so they're actually compressing the latissimus. They're more on the ribs, or they're too high up and they're getting into the brachial plexus.
Okay.
So, okay. So another thing I want to show you is the syllabus. So do you see this APMT syllabus? This is, it's right under syllabus on the, in the course. You'll have to download it and then bring it up. Now, this does not have the changed schedule, so ignore this first part. The topics have also changed a little bit as well. So pay attention to the the document that I posted for you on that. And then this is what we did in October. You actually got a paper handout on this. So you can review this languaging in here. And this is where we are in November. This is what we did. So obviously, we're not following this specifically. We will. This will all get into this. But I want to concentrate the hands-on while we are actually in class on Saturdays. So we did latissimus, pectoralis major, and those work on the frontal plane and the transverse plane. And we did gluteus medius, tensor fascia lata, mostly still working on frontal plane and transverse plane. And we did not get into scalenes and quadratus lumborum. I felt that was too much for the first day. So these have a lot to do with balance and stability. Anything that's on the frontal plane has to do with balance and stability. Then we came down and we did get pectoralis minor. But then we went and started to work around some of the deep lateral hip rotators and started to talk a little bit about what goes on at the hip. And then we did not do sternocleidomastoid and psoas. We talked about these. Okay. So this then shows you the rest of the ones that we eventually will work with. So we still need to work on the scalene quadratus. We need to change a little bit of our approach on anterior serratus rhomboids. We already did pec minor. We need to also work into this idea of supraspinatus, infraspinatus, and subscapularis. Subscapularis is the hard one. Supraspinatus and infraspinatus are not so hard, but subscapularis takes a little knack. And then also how the triceps and biceps interface. We need to be a little bit more specific around the deep lateral hip rotators. And we also need to bring in our sagittal plane muscles, which are sternocleidomastoid psoas. Psoas is, it's underneath a bunch of stuff, so it's hard to access. Sternocleidomastoid is right on the top, but there's a lot of vessels underneath there. So we have to be very cautious on how we work with that. This is a really cool figure that helps you think about how we're going to work with the psoas and quadratus and the erector spinae group. See how they hug the vertebrae? Here's the spinal column, and then these hug right along through there. These are all going to get short if somebody has got lumbar problems. And we just have to make decisions about whether or not they are, it's positive compensation and guarding or not. The other thing is I want you to pay attention here on how far down, this is the pubic bone, how far down and underneath these attachments are. And this is long muscles in through here. So we've got to get them more at the attachments. So this is difficult to access because it's right at the pubic bone, which, you know, is right in the groin area. So that's a big task to get through those, just because the hand placement and stuff is dicey. Anybody got any questions or comments on how that lays out and how the actual handout, the syllabus, gives you additional information over and above what you find in the textbook? And this goes down through. So as you're using this, think, is this something that they need to show me and I need to feel? That will be on Saturdays. Is this something we can chat about or look at a video about or something like that? That'll be on Sundays. All right, that's how that's going to lay itself out. Here's another very cool picture. This would be all about our breathing stuff. But look at how high up rectus abdominis comes. It's way up on the ribs. And then here's our anterior serratus and rectus and intercostals and all that kind of stuff. See if there's anything else of particular interest. You can work ahead and look at these videos. Some of them may or may not still work. That's okay. A lot of support material in here that you can start working yourself through. So over the next month, what I want you to do is just kind of become familiar with all of this. And hopefully that code, those codes will come in this week. We had trouble getting codes for there's a whole thing here on indications and contraindications. The handbook is pretty vast. So stop share. Hi, I'm back. So let's expand this. There, now how much of that did you hear, Erica?
I heard it.
And could you see it?
I could see it, yep.
Okay, so this is more of a visual orientation to stuff. Now, what we do, this is how I'm running this with the entry-level class, because they've got Zoom classes too. But it's not me trying to figure out how to do this on the fly like we had to. It's actually got some pre-planning and stuff that goes with it. In order for it to look like it is embracing a whole day, an 8-hour type class day, I have it divided into a morning segment and an afternoon segment. And with a little assignment in between. So in the morning, it's kind of going over stuff, talking about stuff, and then presenting what the little assignment is. And then the expectation is you'll fool around with that. And then when we get together again for you guys, it's 3 o'clock. We'll talk more about that little assignment kind of a thing. I don't make these where you're going to have to sit and work on it all day. All right. It's, you know, I'm going to try to give you a little bit of heads up on looking at something so we can discuss it or whatever. Okay. And then in the afternoon, we'll reconvene, and there's a separate link for that. And then we'll kind of do that little assignment and then prepare for the, what you're going to do over the next month. And so that you got an idea of what to do with that. So that's how this rolls out. So your little assignment for today is to just scan through that syllabus I just showed you. Look at the headings and the topics, and because there's a lot of stuff in there, so don't try to read it. Just scan through it and come up with an area that you are particularly interested in. Because I have the ability to weight how we're going to use our time. So if somebody is particularly interested in hydrotherapy, for example, which is one of the topics, then I can pre-plan and think what we're going to do with that. If there is already expressed interest in dealing with breathing pattern issues, express that, and I can know, how we're going to swing that. If you are really interested in more in-depth discussion, or you would like me to look through YouTube and find some guest speakers that we can look at. That's what I'm calling all the YouTube videos that I've got up now for the entry-level program. Then I can do some pre-scanning on that, and we can take a look at that. So the little assignment is to scan through and try to pre-plan a syllabus that you would like to see. And then I'll take that all in consideration and, start to think about how we can individualize this for this particular group that are going to be going through it. And we've got John, who is in the loop. You've been in class with John. You guys met him on the Saturday. He's off with the Lions. He's in and out. We've got Heather, who is kind of, she works on the weekends, so she's going to be in and out, and it's going to be a little bit more scattered for her. And then Blake will be in on Saturdays. I've got a pretty good idea of where, her career focus is at. So anybody got any questions or comments of what the little thing is to do for our discussion? And if anything else crops up related to what we did on Saturday, we can do that as well. And the other thing I want to do when we get back is I want to practice something called Breakout Rooms. I didn't use that for any of you guys, but it's a feature on Zoom that we can use where I can put you in groups of 2 or something like that, and you guys can work on a little project for a half an hour, and then you can come back and do a little discussion or presentation on that. So I want to play with that a little bit so that we know how to do that. And that's it. There we go. We did good. And then I will post the recordings for this on the announcements, and that'll give you an opportunity, if you want, to be able to review information or go back and look at stuff. So anybody else got any questions or anything? Ta-da!
I can't get the syllabus to load.
Okay, so I'm not surprised because you're on your phone. It's probably too big. Or,
I'm actually trying on my Chromebook right now.
okay. So see what happens. Are you on a computer right now, Melissa?
No, phone.
Phone.
I was able to get it in both places.
Okay.
I was fortunate.
All right.
Where do you get the syllabus? Because I couldn't, I'm on my computer, but I was trying to get it on my phone and I'm not getting anything.
You gotta go back to Canvas.
I,
All right.
um,
Let's see if I can still get that up.
Canvas.
Can you see me?
I can see you, yeah.
All right. Can you see this screen?
No,
I gotta do screen share.